I'm definitely going to say this is the first time I've given a lecture in a room like this. I'm pretty sure that's an eviscerated heart. And there's an animal with a hat on and heads on plants. So it's a creative environment to give a talk like this. So I want to, just before I get too far, just make some disclosures, because I'll be talking about some technologies today. And I work with a variety of industry partners to develop and test technologies. I'm getting this message. You want me to stand right here? Huh? There's a specific window right about there? Okay. And I also have some patents and companies and so on. So I just wanted you to see that before I get started. So I want to start with a picture just to kind of reorient why we're here today. We're here because we're healthcare providers or we work in healthcare systems. And it's worth taking a moment to think about where healthcare is typically delivered. It's typically delivered in a room something like this. And if you think about it, there's no other room in your life or in our patients' lives that bear any resemblance to a room like this, right? I mean, I challenge you to find some other room in your life that looks anything like this room with this weird table chair and these sinks, and it's very beige and gray. There's this prominent electronic health record right in the middle here that sort of emotionally and physically separates us from our patients. We talked a little bit about EHR earlier. There's this kind of beautiful green, verdant landscape outside, but not inside. It's kind of like going to the DMV. You know you have to go there, and you know there are going to be lines, and everything's going to be beige and kind of gray and bland, and you're going to get some service out of it. You're going to fill out some forms, but then you're going to go home and stay far away from this place. So 99.9% of our patients' lives are not spent in a room like this at all. They're elsewhere, right? They're at senior centers, or they're at work, or they're at home. And most all of the biopsychosocial illness experiences that our patients have are nowhere near us. They're everywhere else but where we are. So the first step of understanding the role, as I think of it, of digital health is to recognize that we need to reach beyond those four walls of the hospital or the clinic or the office or the operating room to where our people are actually living their lives. And that's one of the key principles of population health, is to find the populations where they are. So let's just sort of start with that premise. And you're all probably very familiar with the Hawthorne effect, and I'll explain why I'm talking about this right now. But we know that as soon as we look at somebody or study somebody, they change a little bit about who they are. You're all staring at me right now because I'm giving a lecture. So I'm playing a role of a speaker. If I were speaking like this in a normal conversation, it would be really weird and creepy. I shouldn't use a voice like this if I'm having a regular conversation. So we all put on roles, and patients put on roles, and I've been a patient, and I put on that role as well. You're walking into that little DMV office or that sort of court of law where our residents say things like, the patient denies having abdominal pain. Really, it denies? Like you don't believe the patient? Where did that language come from, that we deny this and patients deny that? We speak as if it's a court of law. So people come in prepared to be at the DMV equivalent and put on certain roles. So what that means is we don't always have an understanding of patients' free-range life experiences. Because of the Hawthorne effect. So we need to find ways to overcome the Hawthorne effect. And passive monitoring is one of those approaches. I'll talk a little bit about that. So let's, again, take a step back about how we're currently delivering healthcare. And this is well understood that there are limitations to how we deliver healthcare. A lot of this has been addressed in some way with the ACA legislation. But the issues are that because we tend to perform care in these rooms, that we can be poorly timed and off target because we don't really know what's happening in the free-range lives of our patients. So there are people right now who will be here in this community who will be in the emergency room in 2 days. And if we had ways of accessing them, we would know right now that they're going to be in the emergency room in 2 days, like the child who's having increasing shortness of breath and wheezing, or the Crohn's disease patient who's having a bowel obstruction right now. And that could potentially be identified with a wearable sensor, but we don't do that kind of work. So we're going to just meet them in the emergency department when they're in distress. And that's how our healthcare system is designed. So we're reactive as a result, not always proactive. There are exceptions. This is completely unempowering to patients and their families, because they often feel like they don't have the information they need at the right time and at the right place to understand their illness experiences and make the right decisions with their providers. And of course, ultimately, this is egregiously expensive, as we all know. So how do we think about the future? It's reversing all those things. It's creating a health system that's increasingly tailored to the phenotypes and genotypes of each individual patient, increasingly delivered outside of places like this, more timely, specific, proactive, empowering, and of course, cost-effective. So that's what the ACA attempts to do. That's what most of us in this room are trying to do. This is, of course, extraordinarily difficult, and it may be impossible. It may be that a lot of the stuff we're talking about today makes for a great conference, but is totally unachievable with the way healthcare is and the way it's currently, and frankly, the way the human body works. It's just the most immensely and difficult problem to solve almost in the world, is to try and fix these things. But we're all here trying to do that, and today I'll try in my own little way to describe some of the ways digital health can help us achieve some of these goals. So we're down here and we're trying to get up here, and what I'll talk about today are 3 different platforms that all have in common they use some kind of computer. They're all digital health platforms. Mobile health applications, we heard about mHealth a little bit in the last talk. Social media, I'll talk briefly about that as well. Certainly heard a lot about that in the last discussion. Thankfully, we have almost no overlap at all, so I'll give it a little bit about social media and how we're approaching that. And of course, wearable biosensors, wearable technologies that I see some of you have on. I've been looking around. Some of you have these on already, and talk a little bit about that. All right. Now, here's a picture. I'll start by saying these gender roles can and perhaps should be reversed. It happens to be drawn this way. But with that caveat, we think about healthcare systems as sort of like these massive organisms. But if we think about a healthcare system as an organism, the cellular unit of that organism is a patient and a provider standing in the 4 walls of a clinic room or an office. This is the cellular unit of our healthcare system. So we have to deeply and fully understand what's happening between these 2 individuals and try to rewire it in a way that improves outcomes and reduces the cost of care. So in one slide, I'll try and summarize, over 20 years worth of research to understand what is it that's supposed to happen in that proverbial 15 minutes that we have with a patient that will optimize outcomes and improve the value of care. Well, there's certain things that we know are best practices, and there's 2 sides to this dyad. The first side is providers, like myself and others in the room. We have to assess our patients. We have to understand initially, what is the patient's agenda? Right? How often do you go to the doctor and the doctor asks you this question? Says, you know what, Mr. Johnson or Miss Smith, what would be a successful visit for you today? Because I want to make sure I understand what the goal of your visit is today before we get any farther with this discussion. Right? How often does that happen? I almost never ask that question. So I've trained a computer to ask it for me. And I'll show you a little bit later what we learn when we actually ask the computer to ask our patients that question, because we forget really simple things like asking that really important question. I happen to be a gastroenterologist, so patients will come to me with a reason for consult, right? The RFC, which sometimes bears no resemblance to why the patient is there or why the patient thinks he or she is there. So I need to understand what is the real reason for this consult. It doesn't matter what was written down in the EHR. That can throw us off on something that has nothing to do with why the patient is actually in front of me. We have to obtain a comprehensive history, identify the emotional context of, in this case, her symptoms, identify educational needs, conduct a multi-system physical examination, and then feedback information, identify and communicate the diagnosis in a way that's understandable to the patient that will improve shared decision-making, provide education, counseling, order the appropriate test, develop a targeted treatment plan, and of course meticulously document all of this in great detail in that electronic health record that's sitting there in the middle of the room. Do that all within 15 to 20 minutes, and do that over and over again every day for days, weeks, months, and years until you retire. And that's the reality right now, and this is why there's a crisis in primary care in particular, right? There's a survey came out last year about 44% of primary care physicians are closing their practices to new patients and or retiring in the last year because they just cannot take it anymore. On the one hand, the screws are being turned to improve productivity in our views. On the other, maintain certain quality standards. And in the middle, both the patient and provider are getting squeezed rapidly. And it's a painful environment, not something that most of us signed up for, and yet this is the current reality. So how do we disentangle this mess and create some tools that can help provide joy, frankly, into the practice of our providers and also improve the care of our patients? That's, again, a remarkable challenge to try to undertake. So as I said, usually all that's happening in these four walls, but she is going to go home, and in this case, he is going to stay where he is. And increasingly, our patients have computers. About 84% of the US population has a smartphone now. Doesn't have to be a big bulky thing like this, a smartphone, a tablet, or some kind of computer. And of course, with the High-Tech Act, we all have computers. So we have computers and our patients have computers, and our patients, of course, can use those computers to collect information that will be helpful to us and then transmit that information to us either synchronously or asynchronously. And I want to give you an example of how we're doing that. So here's an example of an app that we've developed. It's called My GI Health, and we developed this over the last 5 years. It's had support from industry and support from the NIH, and I'll show a little bit more about that in a second. But this is an app that we developed just to, frankly, to help us in our clinic and to develop a model for how we might be able to do this in other areas of medicine. So what this is, this happens to be the web-facing portal. There's also a smartphone application that's now available for free. And patients can go on this system. And when they get on the system, there's all sorts of questions. And it turns out there's hundreds and hundreds and hundreds of questions, almost 1,000 questions on this questionnaire. But of course, patients are not going to answer all those questions. They're going to answer a subset of those questions. So the system uses conditional logic, and it thinks in quotes, what the patient said, and then asks the next most appropriate follow-up question. So we worked with key opinion leaders and some of the best clinicians in the world, and in gastroenterology in particular, and tried to emulate how they take a history and train the computer to do that for us. So if this patient has abdominal pain, then it's going to ask more questions about the location of the pain. If the pain's here in the epigastrium, it's going to start asking about postprandial distress and dyspepsia and H. pylori risk factors. It's going to get right down to it, all the way down to the ground level. And then it's going to give us some information. So we can then receive this information, and we can look at it through our EHR, either through a tethered or an untethered system. In other words, sometimes it could be baked right into the EHR. We could talk about some of this, or in an untethered parallel system, depending on what EHR you're using. And then we can use this information to feed back to our patients, because after all, this patient's not in the same room as we are. Maybe we need to call her in, or maybe when she comes in, we can now look at this computer between us and see things like this. So this is a heat map. Got a little bit messed up in the Mac to PC conversion, but you'll get it. These are PROMIS scores. So we mentioned PROMIS scores earlier in the discussion. So this is the Patient-Reported Outcome Measurement Information System. I think many of you are familiar with PROMIS. Our group created the GI part of PROMIS. And what we're looking at here is an actual patient who's in my waiting room, let's say. And I can see that this patient has a lot of constipation, it turns out, and has, which one of these is the, whoops, that's, whoa, that got funny. Too many buttons, but none of them does what I want. Has a lot of constipation and is in sort of the 85th percentile or so for constipation, and has a lot of abdominal pain, but does have gas, bloating, heartburn, but it's not so bad compared to the general U.S. population. That's what's neat about the PROMIS scores, is it compares against the general U.S. population. It turns out that all of gastroenterology, for those of you that care about the GI system, collapses to 8 symptoms. There are only 8 symptoms in all of gastroenterology from a statistical point of view, and we have characterized those 8. So this is like a fingerprint. For any person in my waiting room, I have a fingerprint of what of the 8 symptoms they have, what combination they have, and how bad they are. So this is the first thing that the computer provides for us, is this sort of high-level review of the patient's PROMIS fingerprint. Of course, we can look at other PROMIS scales like fatigue, physical function, pain, and so on. Now, this happens to be our paper on the PROMIS scales for GI. This is what our mobile app looks like. Patients can use this without having any communication with their doctor. They can have the system take a history from them and then just email it to their doctor or walk it in with a piece of paper. It does a lot of other stuff too I'll talk about in a second. So we all need to document these HPIs, or history of presenting illness. We need to do this. We heard about the medical record as sort of a diary before and how it's been improved over the years and is really meant to be a conversation piece. The EMR or the EHR is not really supposed to be a record of what we're doing to patients. It's really supposed to be a platform for shared decision making with patients. So we should have really nice, clear narratives in the EHR. So as I've been talking, you can see there's an HPI behind me. And this is a real patient. I changed his name as not Mr. Gonzalez, but this otherwise is a real patient. And the computer asks the patient, what would be a successful visit today? In this case, it's to fix my constipation and stomach pain. That is the goal. So I already know that we need to talk a little bit about expectations, because I don't know if I can fix these things. So it's really helpful for me to know that's the expectation of the patient. I may not have gotten that if a computer hadn't taken the time to ask on my behalf. There's an HPI here, and it's very detailed. So if one of my fellows or residents wrote this, they would get a gold star and a high five, because they're covering everything, even Bristol's stool type, for those that follow this stuff. This turns out there's 7 types of bowel movements. Don't know if you knew that. Ranging from 1 to 7. The computer is telling us which of the bowel movements the patient has, alarm features, and so on. So the point of this is, this wasn't written by a doctor at all. This was written by a computer. The computer wrote this entire HPI, and it's now available to us before we've even seen the patient. We have the HPI written already. Now, I may want to improve on this HPI. I may want to throw it all out if I don't like it, or edit it, or use it as a dictation aid, but it's there, and it's ready to go. So we did a study, which we just published this year, a computer-generated versus physician-documented HPI, results of a blinded comparison. What we did is we had patients come in to really good doctors at UCLA, the University of Michigan, our VA hospital, affiliated VA hospital in Los Angeles. And they came in and they had a history obtained by their doctor, which was documented in the chart. And then before they left, they just stopped by and the computer did its own history. The computer, of course, didn't know anything about what the doctor had done. So there were 2 histories side by side. And we sent them out to blinded reviewers across North America, and we said, we're auditing the quality of histories obtained in clinics. Would you help us review them using a standardized scale? So there's some standardized scales. But of course, we didn't tell them half the HPIs were written by a computer. They didn't know that, and they were randomly distributed, and we had multiple reviewers and all sorts of sort of backup plans. In any event, here's what we found. So MGIH here is My GI Health. Whether it was overall impression, how complete the history was, how useful it was, or how organized it was, the computer, quote, outperformed the doctor at taking a history. We then had Medicare billers look at this. We had them audit the billability, I guess, of the HPI, and 100% of the computer-generated HPIs could be billed at the highest level of complexity versus 84% of the human histories. So what does this mean? Does this mean we've replaced doctors? There was this is a funny recent New Yorker. You can't list your iPhone as your primary care physician. It says. The LA Times covered our article and said doctors are no match for computers at accurately recording patient symptoms. So we said, no, this is exactly what we told you not to write. We told you, I had a whole phone conversation, we talked about it, nowhere did I say they're no match. And in fact, the article is quite fair, but they have to sell copies, so that's what they wrote. So the point we tried to make here is, there's no replacement for a human. Watson is great at playing chess, but I'm telling you, it cannot do medicine, not yet. There's a lot of people who disagree with me, but I would stand up and fight them tooth and nail. It cannot do medicine yet. A chessboard is different. A chessboard, we know every move that's possible. It's a completely known data set. It's a complex one, but it's completely known. Most of the data we work with in healthcare is incompletely known. Even just think about the symptoms that we obtain from patients. What does fatigue mean? What does that mean? Because it's different for different people. Is it a binary thing or is it continuous? What does bloating mean? I mean, we've had debates in our national meetings. We have a whole, every year we have something on bloating. There's like 6 people that get up and talk about bloating. I mean, that's how detailed it is. How are we going to put that stuff into a computer that's going to start making diagnoses when the data that's going in is almost uninterpretable? Even the stuff that we use that's really objective, like lab tests we saw earlier, lab tests are inaccurate, right? How do we interpret those? So we have a big problem using computers to make diagnoses, and we can talk more about that. But computers are really good at collecting data. And this is an example where a computer can take the time to collect data and present it to us in a way that's meaningful and potentially helpful. So we're doing a study now with the NIH to compare use of this system versus usual care, looking at patient outcomes, patient satisfaction, their experience with the doctor, shared decision-making outcomes, and so on. And that's really the ultimate test of something like this. Otherwise, it's just me showing you, slides and images. So we'll find out soon if it's doing any better or not than usual care. And maybe I'll come back and report that at some point. This is a recent meta-analysis that looked at the accuracy of 23 online so-called symptom checkers. And if you want to get diagnosed with something, run far away from an online symptom checker. You'll have disseminated syphilis or you'll have something horrible other than whatever you actually have. So that's pretty much been established. That's the state of the art of symptom checkers. Okay, so we kind of continue this cycle. I've been talking about A, where patients can go onto computers, and then we see some data, and then there's a conversation that happens. I want to talk a little bit more about how computers can help us in that room, because I started by saying how difficult this is and complex it is and so on. So what's happening in that room? This is an example of what our system does next. So it'll look at the patient's PROMIS scores and HPI, and then it will automatically draw up what we call an education prescription. So we work with the Center of Health Communication Research at University of Michigan, Ann Arbor, and they have developed this whole educational prescription module that ties into our HPI taker. And this particular patient, who is a male, and actually the figure will change depending on whether it's a male or female, has constipation. And it'll then pull up all sorts of education videos and information that the patient can see even before they come in to see me. Here are some of the screenshots of different videos that come up. In the room itself, I can pull these videos up through the console and just show it to them. It's like a minute and a half. So rather than having trifold brochures all over the place or whatever, I can just say, hey, you have acid reflux. Let me tell you a little bit about what's happening. There's this thing called the lower esophageal sphincter, and it opens, and it's all animated. Here's another screenshot for somebody who has biliary problems. This is a video that describes the so-called brain-gut axis, the communication between the brain and the gut. People who have chronic abdominal pain or irritable bowel syndrome often have stress-related pain or discomfort in their belly. Very difficult concept to describe in 30 seconds or a minute in a clinic, but just beautifully described in a video. And if the patients need to see it again, they have it sitting on their app or their computer at home because their prescription has already been drawn up for them. If anybody's keeping track here, pre-lunch image of a piece of poop with bacteria frothing on its surface. This is an interspace journey through your colon, and it describes how your poop is made. And it's like the most compelling minute and a half of educational video I've ever seen. And what's amazing about this is I'll play this in the room, and the patient's looking at this, and their jaw just drops to the floor. And I literally think to myself, like, this is patient engagement. That patient is engaged. Totally engaged in this moment. This is a learning moment. But it's actually beautifully done. It's actually very, very compelling. So anyway, that's a little bit about that. So our patients are not always in the room with us. They're outside. They're in other places. So this brings us to the sort of next topic of passive monitoring, because passive monitoring is powerful. It's powerful because it overcomes the Hawthorne effect, which we talked at the beginning. And with that background, we've been developing this sort of 2x2 table of measurement for how we think about monitoring our patients. And if you think about it, there's sort of subjective data, right? The quality of life data, patient-reported outcomes. patient satisfaction, HCAHPS, all sorts of subjective data. Then, of course, there's objective data, the physiologic parameters, and so on. We can measure this information or these data actively, where we ask people to give us that information, or we can sit back and listen passively. So there's 4 opportunities here. I've been talking already a little bit about the upper left, where we can administer surveys, like through a mobile health application. We can administer patient-reported outcomes, which will be increasingly important with Meaningful Use 3 legislation now coming around the corner. But that's active, where somebody has to fill out something for us. This is the world of social media, as we think about it, where we can sit back and listen to massive populations talk about everything that's on their mind. I'll give you some examples. And this is where biosensors fit in, both actively and passively can monitor data. So I'll give you some examples. Let me start in the upper right. I'll give you my few minutes on social media. So this is where I would usually ask the same question that was just asked, which was how many of you have a Twitter account? And I turned around, I think I maybe counted 5. Was that what you got? So it turns out, I gave a talk, this is so funny, because I gave a talk recently, there are 350 gastroenterologists in a room, and I said, how many of you have a Twitter account? And 5 hands came up. And I gave another talk recently where there were about 100 people, and 5 hands came up. It turns out no matter what the size of the room is, there's 5 people who are on Twitter. That's it, unless it's a pediatric conference, where I gave a similar talk where 1,500 people in the room, and 1/3 of them raised their hand. And because they know their patients, their stakeholders are engaged and connected, so they have to be connected too. So in any event, in healthcare, we're not very representative of the rest of the world, but a lot of people are on social media. And before we get too much further, just to talk a little bit about the ethics of this research, the IRB is pretty comfortable with this, because as soon as somebody clicks this button, they have agreed to what you say on Twitter may be viewed all around the world instantly. I agree. Pretty good IRB. Our IRB is pretty okay with that. And this is from the Twitter privacy policy. This is a picture of Europe. And it's a little bit granular, but you can make it out. And it looks kind of like a satellite image of Europe at night. But as you look more carefully, you'll notice that some of the, like the lights of Portugal are different from the lights of Spain, and they shouldn't be color-coded. And that's because these aren't lights at all. Every one of those lights is somebody using Twitter in Europe. And you can see just how incredibly penetrated this social media platform is. Moreover, this is only 5% of Twitter users in Europe. These are the 5% that forgot to turn off that geolocate button that the rest of us turn off, so they could be geolocated. These are people getting on airplanes that they can't wait to tweet, and they tweet, I'm about to get on an airplane, and they land, I just landed. And then this guy, Eric Fisher, just connects the dots and sees where they flew to. And you can see people moving all around the world. This is my city. This is Los Angeles, California. And there's some really interesting things as you start to look at this. I don't know if any of you have been to LA, probably some of you have. I don't know, does anybody recognize what this is right here? This is the ocean. What's that? Venice. Venice is about right here. Yeah, this is Santa Monica Pier. And it is full of people who can't wait to tweet about being on the Santa Monica Pier. Here they have this beautiful view of the ocean, and they're tweeting about it. There are people on the 405 freeway, the San Diego freeway, tweeting about being on the freeway. This is where I spend a lot of my time. This is UCLA. I teach in the School of Public Health in the medical school. And I give a talk like this, and I say, I don't know how many of you right now are tweeting during this talk, but quit it. Because all of you guys are busy on social media. And how do you do that and study at the same time? So there's lots of interesting things you can find when you look at these things. So social media is being used extensively in healthcare. And this is a really nice white paper about it. And there's a bunch of different ways social media is being used. And I want to just talk about a couple of them that we didn't talk about. Certainly patient affinity groups is one that you heard about in the last discussion. The Mayo Clinic has really been leading the way in helping us think about how to use social media as a massive epidemiologic research tool and as a patient engagement tool. And they developed the Mayo Clinic Center for Social Media. This is a nice monograph that they've published. You can go on Amazon and buy it. It's like 100 pages, and it's okay. Talks a little bit about how they're using it. I say okay because this stuff gets like outdated within a few months of being published. So it's a nice sort of starting point. And an amazing example, I think the most amazing example I've ever seen of social media is a story of the so-called SCAD Ladies. They called themselves the SCAD Ladies. So this is spontaneous coronary artery dissection. And SCAD is a very unusual condition, very rare, where the coronary arteries can rip themselves apart just spontaneously and people can have heart attacks. And this story started with a relatively young woman, I think she might have been 30, who is a mom, and I think somewhere in the Mid-Atlantic coast, I can't remember. But she walked in the emergency department with some atypical chest pain and was told, okay, this is a stomach ache or something. It's not a heart attack because you're a young woman, so go ahead and have this Rolaids and go home. And she came back again, said this isn't getting better, this is unusual. And they said, okay, you have to take 2 Rolaids and go home. And then she came back a third time, almost dead, because she was having a spontaneous coronary artery dissection and was saved, barely, lived to tell about it, and went online and said, this is what happened to me. And she found this cohort of something like 30 or 40 other, generally women, who had the exact same story happen to them. And they all got together and they said, we need to tell our story to somebody because this can't continue like this. So they organized themselves and they walked themselves into the Mayo Clinic. And the Mayo Clinic wrote an article called SCAD, a disease-specific social networking community-initiated study. I've never heard of a study design like that. And this is no joke. The first author's last name is Tweet. So what do they do here? They describe this approach where they can identify participants via disease-specific support groups on a social networking site. They bring them in, confirm their disease status, and then do detailed surveys and measure all sorts of information about their clinical experiences, their sort of epiphenomena. And then they look into the genetics and do DNA studies and multi-center registries. And it's this massive engine that basically is fueled by the power of social media. Such an interesting and important example of how social media can be used. This is another example at the University of Iowa. I haven't seen this written up fully yet, but this is an example where the problem here was kids who get renal transplants. They feel better all of a sudden, and they're at this very vulnerable age when they don't want to take their anti-rejection meds. They don't want to take anything. So they can reject their kidneys. So it turned out one of the kids of a transplant surgeon, overhearing, I think it was his father, talking about this problem, said, you need to meet them where they are. They're on social media. So meet them on Facebook and set up an account, private account, where you contact them and then you ask them if they're taking their meds and they'll like it back if they do. And they have reported that this has improved adherence and reduced rejection of their renal transplants, although I haven't seen this written up fully yet. And we had a conversation last night. We're not even sure if kids are on Facebook anymore, which is another interesting discussion. So a couple other examples. Here's the United States now. This is Twitter usage in the United States for the 5% of geotagged users. And now what I'm going to show you is a map of the United States again, but now we're working with our natural language processing experts at UCLA, and we're specifically looking for a subset of patients. These are patients in the United States who have Crohn's disease. So we can now reach out and find people with Crohn's disease or a variety of other conditions using these NLP algorithms. And they're not perfect, but they're pretty good and probably better than ICD-9 codes. We can talk more about how they're validated. I can look in Southern California and see where they are and what they're up to. We can then listen in and use kind of mixed methods approach and qualitative analysis. This is Atlas TI, software program, looking at how people with Crohn's disease cope with their illness. They cope through humor and through determination and positive thinking. Or we can start to look at what symptoms are being reported by these tens of thousands, actually hundreds of thousands of people, and start looking at statistical correlations between symptoms, sort of higher level factors, to see if there are kind of different types of patients with Crohn's disease. So these are examples. This is the actual line-by-line tweet. We just finished a study that I'll show you in a second, looking at use of narcotics in the United States as reported on social media. And you can see really interesting stuff. Dear morphine, thank you for taking away the pain, but you also took away my ability to walk without falling. Not cool, man. Not cool. Okay, that's This is a line of data. Okay, pain meds in my stomach are arguing right now, and I'd like that to end. So we have over 2 billion tweets that pertain to narcotic usage. And then we also worked with a company called Trito that was able to screen scrape over 3,000 online health forums to specifically collect data around narcotic usage and in the United States. And this is a paper this is in press now. This is the galley proof. It'll come out soon, looking at how patients in particular deal with gastrointestinal side effects. You can see that's kind of my theme medically. With pain management, and there's some really fascinating results that come out of this kind of work. This is a study that was in Science that looks at sentiment or quality of life, essentially, minute by minute as the day goes on. And there's really interesting circadian patterns, right? So in the morning, good time to give a lecture, people are pretty happy. And then at around noon, getting close right now, what time is it? You guys are starting to wane right about now. This is a terrible time to give a lecture. Then people, they get off of work and they feel better. But it happens every day of the week. It's the same pattern all around the world. And this is using sentiment analysis, looking at the type of language that's being used and scoring it on positive or negative valence scales. So we're doing the same. We have a grant from the Robert Wood Johnson Foundation right now, where we're trying to figure out if we can accurately measure health-related quality of life of Twitter users by looking at the sentiment of the language that they're using in their tweets. And you can imagine there's a lot of issues and complexity with that, but the idea is we can follow individual patients over time and see what their quality of life is like if they have enough tweets. And we'll have more information on that soon. We've recruited 1,000 people on Twitter, and we are monitoring them, and all of them we have baseline, like gold standard quality of life data, and we're then going to see if we can train a computer to find what the quality of life is in those patients using the sentiment analysis. It may blow up and be a total failure, but that's fine. That's why we do research. Okay, last bit of my talk. Let's move down to the biosensor piece. I haven't talked a lot about this. I heard some discussion about Fitbit earlier. Let's talk a little bit about this. So, incredible statistic. Does anybody not have a smartphone on their body right now? Good for you. Good for both of you. Somebody has to not. In every room there's one or two. There's two here that don't. So that's excellent. The rest of us, in case I get a call in the middle of this lecture, I'm ready. I have my phone right in my pocket. So we keep these things right next to us. We sleep with them right next to us. We get twitchy when we're in the shower because we're kind of separated from it. It's weird. So there's a lot written about that. But the good news about that is it's a powerful digital portal that allows us with with ubiquity of Bluetooth and wireless networks to collect information from our patients and port it directly into an electronic health record. And we've been doing that at Cedars Sinai with our Epic system. So I'll show you that. But this gives rise to the quantified self-movement, which is this movement to use apps and sensors to quantify inputs and health states and functions. And these are some examples of inputs, states, and functions that we can monitor with these data. Now, we talk a lot about PROs, patient-reported outcomes. I think of this as PRIs, patient-reported informatics. So there's PROs and PRIs. They're all patient-reported data, or PRD. But that's more sort of taxonomy stuff. Okay, so who here has one of these on? I saw a few. Okay, good. What do you got there? Is that you're holding up your iPhone? Oh, yeah. Which one is that? What's that? It's from China. I don't recognize that one. That's interesting. I usually recognize them from afar. So I have an Apple Watch on, which is kind of a gimmicky watch, by the way. But that's another discussion. And, so you got one on too? It's gimmicky, right? You like it?
I won it as a door prize at a conference.
I got this for free, too. Yeah, I want my Fitbit back, though. You praised your Fitbit. That is so funny. So only, the people that get them for free wear them. Okay, so there's lots of sensors out there. I have nothing to do with these companies, but we happen to be using Fitbit more and more. The battery life is excellent. It works well. It's reliable. I'll show you how we're using it. Now, at Cedars Sinai, where I work, we, earlier this year, connected our electronic health record to Apple Health Kit and to a variety of wearable sensors. So right now, we have over 80,000 people who are on our patient provider portal on Epic, who, if they wanted to, could upload in real time their health kit data from their iPhone, Fitbit, Withings, Jawbone Up, and a variety of other sensors to measure steps and heart rate and blood pressure and distance and all these great things. And we got all sorts of press attention for it, which is wonderful. This was work that was done by our EIS. The leader is Darren Dorkin. He's done a tremendous job of kind of collecting all this data and getting it to our clinicians. So now we're trying to figure out, what do we do with the data, right? It's great to have data, but could you imagine if Boeing one day sent an email out to all of its 777 pilots and said, guess what? Good news. Starting today, we have some new data in the cockpit, some new consoles for you, and just see what happens. Let's go with it. There's no training, there's no kind of, Boeing would have had flight simulation and they would have developed it. So here in healthcare, we say, we got an email one day, and we said, guess what? Now you got the data. So, well, what am I responsible for this? Oh my God, what if the patient's having a heart attack and tachycardic and hypertensive? Who's in charge of that? No, you guys work that out. So no, to tell the patients no one's looking at the data. Well, then why are they giving us the data? Oh, so that we can use it in the clinic. And then you can make decisions. So, okay, this is wonderful because this is great infrastructure, but we need to figure out how to use the data. So that's what we've been working on. Here are my data, by the way. I like to put up my data. This is kind of typical for me. I went for a run last night. So here's my sleep. So when I see stuff like that, I think I have to do something about it and sleep the next day. And this is from another day. But I was a champion this day, and really everything went well that day. So we have lots of sensors we can look at, and we've been experimenting with a lot of these sensors. I just want to give you some examples of how we're thinking about using it. In particular, we've been working with our colleagues in rheumatology, Michael Weissman in particular, using sensors in patients with rheumatoid arthritis, which is a really good example of a condition that affects mobility, steps, and so on. So we thought, okay, let's put on this really souped up super sensor. We work with our colleagues at UCLA and the Wireless Health Institute. This is used for professional runners. It has a gyroscope in it, and it goes on the shoes, and it can talk to you in your ear like a professional coach, telling you if you're pronating too much, supinating, foot contact time, stride dynamics. The winner of the LA Marathon had this on when he crossed the finish line, well ahead of me, by the way, with this on his body. And on the news station, they actually were showing his data in real time so that everyone can actually see the front runners. And at mile 13, the system was able to predict who was going to win the race and was accurate. Actually accurately predicted who was going to win the race. If you're thinking that we can use this on horses, it's already been thought of. So I'm sorry to ruin that. It is being used on horses. So we can look at where people are walking and monitor this on apps. And it's great. So here's the thing, though. I really want to show you this, some actual data here. So what am I showing you? This is our very first patient in this pilot study. And it is so important to understand this subject. Because here's a patient who's getting etanercept, a biologic therapy for RA. And on the left panel, we are monitoring this patient's PROMIS scores. And you can see that this patient's pain is getting better. It's going down. Definitely getting better. And here on the right panel, we're monitoring remotely the steps. And the steps are not getting better. The patient is not moving virtually at all towards the end of this 30-day trial. So I said, oh my God, she's not wearing the sensors, of course, or she gave it to a friend to wear, or she's not turning it on, or the battery's died. Let's make sure, no, I'm wearing it every day, no problem at all. So well, how can that be? How can it be that you're feeling so good, but stopped walking? Well, it turns out you have to talk to people. You can't remotely monitor things from an e-coordination hub. So we spoke to her, and she said, oh, well, you know what? It turns out I'm an author. It turns out she's a writer. She writes books. And she said, I'm feeling so good. My lower extremity arthralgia, stiffness is so good. I can finally sit down and do my job. I can sit down and write a book. 11 hours at a time. She's like, when you're hot, you sit down and you write. That's what she said. That's her quote. And we thought, oh my God, of course, right? I mean, how many of you are walking right now? At work, we kind of sit. So we allowed her to go back to work. So we can't just, this first example, like undermined our presuppositions about what is the meaning of wearable sensor data. So we're now trying to understand this in a larger cohort, and there are definitely relationships, but it's not so cut and dry. And we'll report more of that as we get more data. Other things that have been very popular with wearables, sleep in particular. We know our patients with chronic disease can all benefit from sleep, both quantity and quality of sleep. And this is an old sensor from Zeo. It's old. It's actually off the market now because it's been replaced with better sensors. But I show this because it was one of the original ones and the most validated one. And what's amazing about this is this $100 device can look at sleep architecture in great detail. You can see this is from 2009 now. And what's amazing is this is how we normally do that. We get somebody, say, here's what we're going to do, sir. We're going to put you in this room that looks kind of like a hotel room. There's a one-way mirrors. We're going to wire it up with lots of cameras. We're going to put some wires on you. We're going to charge your insurance about $2,000. And we just need you to go sleep for the night. That's how it's going to work. And so when they looked at this, they looked at this is a correlation plot looking at TST or total sleep time between the full polysomnography and the Zeo sensor. The R value is 0.97. So you don't see this like in science. I mean, this is not a normal, it's a perfect correlation. It's a perfect replacement for the full sleep study. So this is one of the best early examples of wearable sensors being used as a surrogate for the usual way of doing things. This is the Q sensor out of MIT. And what this is a wrist bracelet that measures galvanic skin resistance. So it's a measure of stress. So this is really interesting because this is an old technology that's been used, in mental health for a long, long time. But here it's just been miniaturized and made portable and mobile. So you can see minute-to-minute changes in people's stress level. And this is a validation looking at physical stress. You can see there's different people. Some are in really good shape and some are not. Cognitive stress. And this is the best method section of a paper I've ever read. This is 5 minutes of a zombie movie. I forget which zombie movie it was, but they describe the scene. There's lots of things that look kind of like these murals, things getting cut off and weird. And here's somebody that's freaking out about it, and here's a psychopath that's really comfortable with the whole thing. Nothing going on. So you can distinguish people with these sensors. This is the Muse, which is out of Canada. It's a sensor goes around it's basically an EEG. And what's amazing about this is you can look at an iPad. There's a metaphorical narrative of what's happening in your mind. So if you're calm, you see this bucolic countryside. There's a barn, and there's birds sort of flapping around. But as you get stressed, the clouds come in, the lightning starts to strike, and you just see what's happening in your mind and you try and control it. It's funny, the marketing materials around this, that we cannot read your mind. We just want you to know that, so in case you were worried. So this is another example of a technology that maybe we should start thinking about for our patients with chronic illness. Virtual reality. Has anybody used virtual reality before in here? No? Well, you got to get some goggles on soon because it will blow your mind. It's amazing. So this is called Google Cardboard. And we're using Google Cardboard in our hospital now. I'll explain that in a second. But this is a $10 piece of cardboard that you can roll up a smartphone into. And when you put them on, your mind is hijacked, just totally transformed. Now, there's really high-end goggles like the Oculus goggles, and I've used those as well. And the idea behind virtual reality is you get yourself into these goggles and you are now in a completely different world. And you look around and you can see a new environment. It could be on a beach, or you can be in Iceland. Or in my office, these guys put me on the top of a skyscraper and they said, okay, now just take a step off. And I was like, no way, I'm not taking a step off. And I said, well, you know that you're in an office. I'm like, I know that, but I'm not stepping off this building. So finally, like, just do it, and I'm kind of cheating, and I can kind of I'm feeling the carpet, and it's just you can't stop yourself. So it could be used for evil, but it can also be used for good. So we have a protocol now where we're taking our inpatients who are on narcotics and pain, sitting around either in pain or bored to death in a hospital bed, and we're transporting them to Cirque du Soleil concerts and to Iceland and to the beaches, and we have this kind of pain intervention. There's also a similar intervention we're testing out now, just starting to test out for weight loss, where you can see an avatar of yourself in a mirror, like 300 pounds overweight or at a healthy BMI. And it's tremendously compelling and eerie to see yourself healthy in a mirror. And this is something that with $10 and smartphones people already have, we can potentially use in a lot of different environments, underserved and otherwise. As I said, 84% of the population has a smartphone. So we're exploring that now. I'm going to skip this. I'm going to skip that, skip that. So I'll go one last example of a sensor, and just to give you a little bit about how we develop these sensors and test them. So as I said, I'm a gastroenterologist, and I've been following this literature and noticing that every part of the body has been instrumented, but there's this big part in the middle that no one's really instrumented yet. And I was thinking one day, well, maybe we can do something there. These other examples are really important ones. The Zeo Device is now commercially available. It's basically a Holter monitor, measures EEG. And importantly, there's a service available, so somebody actually is monitoring that 24 hours a day, right? And unlike me, I'm not going to be able to monitor my patients 24 hours a day. This is an FDA-approved device that goes on a metered dose inhaler. It's by Propeller Health. And every time the MDI is squeezed, it triggers the sensor. But the sensor also looks at where is that patient, what are the particulates in the environment at that moment, and are there patterns to this patient's asthma or COPD flares? Can we detect if somebody is deteriorating quickly so that child or that person or whomever who's going to be in the ER in 2 days, we can see right now is headed there because things are getting worse. That's the Propeller device. So I kind of created this thing. It's called ABStats. And I was thinking one day, boy, there's a lot of stuff that the intestines do that, might be worth monitoring in a non-invasive way. So created this sensor. It's a disposable sensor that sticks on the abdominal wall with Tegaderm. And it has a little microphone inside of it. And the microphone is constantly listening to you digest your food. And a computer then is monitoring those signals and can try and make sense of them. So this is an example. We're using this in our hospital. This is a bedside computer, and it calculates, it's sort of a new vital sign. We call it the intestinal rate. You get your heart rate, respiratory rate. This is your intestinal rate. This is the number of acoustic events per minute that correspond with motility or movement. So we can monitor after like a surgery, post-operatively, we put these on our patients and we monitor their intestinal rate minute to minute so we know when to feed them and how to feed them. So we don't, give people too much food when they have ileus, or wait too long when they really need to be discharged and they need to get their food going. So this is an issue on the surgical service. And this is an actual view of what we also call it Telebelly. And this is not an EKG. This is a acoustic strip of a patient who's recovering from postoperative ileus. So this happens to be what it looks like. So I'm sorry for all the graphic stuff, but here's an ostomy. This patient had a gunshot wound and was in the operating room and then enrolled in the study. And we've got 2 sensors, so we're monitoring this patient's abdominal signals. It turned out the sensors predicted that he would get ileus, and sure enough, he's got a bloated belly, and he did get ileus. And that was clear from the first 24 to 48 hours of signals that the sensor detected. So we published a paper on this, and the key to these things is we have to study it like any other biomedical advance, whether it's a pill or a smartphone app or a social media intervention or a wearable sensor. We need to study it. There's a lot of this stuff out there that's not being studied at all, but there's lots of proselytizing and technophilia about the stuff that's out there. So that's my editorial for a second, but we've been studying this stuff. And after it came out, there was a lot of press attention. I just wanted to show you this guy. You've seen me already, but this guy here, his name is Bill Kaiser, and he runs the Wireless Health Institute at UCLA. And this is a guy that helped to invent the cruise control system for General Motors early in his career. And then he went to the Jet Propulsion Laboratory and worked on the Mars rover vehicle. But then he came to UCLA and created the Wireless Health Institute. And he says of all the things that he's done in his career, nothing comes close to the impact that he thinks he can have on humanity than his work in wearable sensors. So more important than spacecraft and cruise control systems in his experience is wearable sensors. So that is a compelling and profound statement from somebody like that. One last picture I'll show you. After this press attention came out, we were contacted by vets who said, you know, we literally do veterinary medicine, and we cannot hear anything. Our patients don't talk to us. In particular, horses get ileus. I don't know if any horse owners in here, but they get ileus, and these are expensive animals. So here I am at Santa Anita Racetrack with a thoroughbred racehorse and fitting it for a biosensor. And we're now using these sensors on horses and dogs and small animals, the VCA hospitals. I saw you had a VCA here too, who are using these now to predict postoperative ileus after surgery for dogs. So who knows, this stuff goes in crazy directions, and that's just more of an aside. If anyone's interested in this stuff, I strongly recommend you read these books, particularly the last one. This is by Bob Wachter from UCSF. He coined the term hospitalist, and now the new term is digitalist. So the digitalist is a new type of healthcare provider who understands patients and their biopsychosocial illness experiences, but also understands data and their sources, and can put them together and sits behind an e-coordination hub and is monitoring populations of patients at scale and is able to make decisions in real time to keep them away from the healthcare system, away from the hospital. And this book summarizes that vision, but importantly, it's called Hope, Hype, and Harm. And it's a very balanced view that a lot of this stuff is never going to happen and can't happen, but some of it can, and he talks a lot about it. This is Eric Topol. The patient will see you now. So there's a lot of people that contributed to this work today. This is about half of our group. We've grown since this picture was taken. And there's a lot of individuals and people that have helped with the work. Thank you again so much for inviting me. And sorry I went on a little bit long, but appreciate your attention today.